Bueno, pues muchas gracias. Vamos a pasar ahora a las dos conferencias inaugurales plenarias de este Congreso. Son dos conferencias que van a reflejar el espíritu y el lema de nuestro Congreso, de la ciencia a la población. Esperemos que las disfrutéis. Santi va a presentar a nuestro primer ponente.
Sí, la primera conferencia inaugural, habéis visto en el programa, que lleva por título La ciencia detrás de la estrategia 90-90-90. El ponente es Bertrand Audoin. Bertrand tiene una larga historia de dedicación a la infección por el VIH. Por solo mencionaros unos pocos hechos que hablan de su compromiso con la pandemia, os comento que Bertrand ya se implicó a principios de los 90 en programas de prevención en la comunidad gay, mientras él trabajaba en otra cosa en Auckland, en Australia. Luego trabajó durante 15 años más como director general de SIACción, que es una ONG francesa. Ahí desarrolló programas de prevención y de cuidados tanto en Francia como en algunos países pobres. Ha sido luego director ejecutivo de la International AIDS Society, la IAS, y en la actualidad es el vicepresidente para iniciativas de salud globales de la IAPAC, la Asociación Internacional de Médicos de Cuidado del SIDA, que tiene a más de 160.000 profesionales sanitarios en más de 100 países en el mundo. Precisamente la IAPAC tiene, entre otros programas, la iniciativa Fast Track City, que es la que comentábamos antes, en la que ya sabéis que Madrid y otras ciudades españolas se encuentran incluidas y han firmado. Por todos estos motivos que os comento, por su compromiso repetido en la lucha contra el SIDA y por lo bien que lo hace, es un placer tener aquí y poder escuchar a Bertrand.
Can you hear me? Yes. So I'd like to first thank the organizers for having invited me to make that presentation tonight, and I have to apologize to all of you because, as you can hear, I can only speak to you in English, ou français si vous voulez. I don't speak a word of Spanish, so I have to apologize for that. So I will talk to you tonight about the science behind 90-90-90, given that I'm not a scientist or even a medical doctor myself. And I will talk to you about one example of the implementation of 90-90-90, which is the Fast Track Cities initiative that I coordinate for Europe. So I'll start with a background and taking you 5 years back, and just taking you 5 years back sometimes looks like 1 century ago, but it wasn't, on why and how the 90-90-90 targets were created and decided. First, you must remember that before we had 90-90-90, the last a big international political meeting on HIV was the high-level United Nations meeting on HIV and AIDS in 2011 in New York that set targets for 2015 and 2020, and that made it clear that UNAIDS and WHO were to come up with specific, bold, targeted objectives to be reached by 2020 and 2025. So there was a political pressure on UNAIDS and WHO to come up with international targets. Then you may remember in 2011, and that's the right side of my slide here, that at the Rome conference, the IAS Rome conference in 2011, where presented the results of the HPTN 052 study that actually showed that treatment is prevention, and the one figure that everyone remembered from that presentation is this 96% efficacy of treatment as a prevention tool. Then 2 years later, in 2013, we had the new WHO guidelines that are now implemented in most countries in the world that recommended treating everyone under 500 CD4 count. So there was a momentum at the time to build new global targeted objectives for the fight against HIV/AIDS. Now you all know, but the trends, even at the time, were very clear that the number of people accessing treatment and the proportion of people living with HIV who were accessing treatment had been increasing steadily over the past 15 years, actually. And in 2014, we were up to about 15 million people on treatment and 46% of ART coverage in limited and middle-income countries. And at the same time, the cost of treatments was reducing quickly as well. That's what the right graph shows. The green line is the price of pharmaceutical drugs, and the yellow line is the price of generic drugs. That has decreased very rapidly, allowing for a larger number of people accessing treatment. We all knew as well, and I always try to show this line because I think it's really telling. We all knew that the quick transformation, the quick evolution of ARV treatments from the first multi-therapies in '96 to the ones we have now allow for a long life expectancy of people who actually start treatment. So you can see here that the life expectancy of a 20-year-old who would start a treatment in '98 or 2000 with the latest treatment was 36 years. Today we're up to 55 years when the global population is 60 years. So actually when you find out that you're HIV positive now and you have access to the latest treatment, your life expectancy is almost similar to the one of people not living with HIV. And at the same time, we knew, and we still know, that global and expanded access to HIV treatment has a global positive societal impact on the global life expectancy. So the top line is actually the growth in the life expectancy in the world from 1960 to 2012, and then the different lines below are the evolution of life expectancies in selected countries in Africa. That's where you see the steep decrease in life expectancy when the HIV epidemic started, and then the life expectancy increasing again when these countries starting having access to treatment. So the impact is a medical impact, obviously. It's a public health impact as well, and it has an impact on the global economies of the countries as well. One thing that you should know, Michel Sidibé, the director of UNAIDS, told me a few months ago that when he visits a country now, he has an appointment with the Ministry of Health, but he also always have an appointment with the finance minister to show to the finance minister that investing in HIV, increasing the budgets for HIV prevention, HIV care, and HIV treatment is actually sound and is actually a good financial decision to make at the country level on the middle and long term. And I think that says a lot. So why did we choose 1990? There were a number of expert groups meetings and a lot of meetings at UNAIDS and WHO in 2012 and 2013 to discuss what the global new target could be, given that we needed figures and we needed something that political leaders who don't work on HIV could easily remember and easily keep in mind. And we actually chose the model that is used for vaccine research. And you might know, you know better than me, that on vaccine research, a vaccine is considered by WHO and by most country regulatory bodies as highly efficient if it is efficient for 90% of people who receive it, right? And it is considered efficient from a public health perspective if 90% of the target population of the vaccine has access to it. So we actually copied this model to define targets for the HIV/AIDS fight. You may remember at the time, and we still do, discuss a number of different topics: end of AIDS, epidemic control, AIDS-free generation, and many more. We had to focus on one that we thought could encompass all of these targets and speak as one, if you want, and that's the one that was chosen at the time. Why it was chosen is because all the data that were gathered by UNAIDS at the country level showed that this was achievable. And I will show you some of these graphs, not all of them, but some of these graphs. This is the proportion of people living with HIV who got tested at least once, and that's from 2010 to 2012, in selected African countries. And you could see that even 6 years ago, these figures went from 40% to almost 90% actually in Rwanda, and over 80% in Malawi. You also see a discrepancy between men and women, with women getting less tested, with men, sorry, getting less tested than men, which is obviously an issue. But this kind of graph showed that targeting 90% of people living with HIV having been tested was achievable even in limited and middle-income countries. That is a graph that shows in selected countries, again, the retention on treatment after 12 and after 24 months in selected countries in Latin America and the Caribbean. And what you can see there is that the median at the time was 80%. So actually putting people on treatment and keeping people on treatment, which is obviously key to getting an undetectable viral load, was also achievable in most parts of the world. And this is the proportion of people on treatment with an undetectable viral load in a selection of sites in Rwanda, again in 2013. And you can see on the right that the average was 83%. So already before we had 90, Rwanda was not so far from the third 90. So again, this showed that in countries that have many challenges, getting to 90 was achievable. This is what the situation was like in 2014, the global situation as reported by UNAIDS. So 75% of people living with HIV knew that they were HIV positive globally, which meant that 25% did not, but which again was not so far from 90%. 60% of people who know that they're living with HIV were accessing treatment, so there was a gap there, but again, a steep increase and a quick way into filling the gap from the previous years, as I showed earlier. And only 47% of people on treatment had an undetectable viral load. So that was the biggest gap that we had, and probably the biggest that we still have globally. So we had targets, we had objectives, and we knew where we stood. We also looked, UNAIDS together with WHO looked at the projected impact of the 90 objective if they were to be implemented globally and in every country. So the graph on the left shows you the number of new HIV infection. The green line, is the number of annual new HIV infection if nothing changed in the country programs and in the current program that were in place in 2015. And the blue line showed you the impact of implementing 90 in all the countries. The graph on the right shows you the same difference and the same discrepancy between 90 and business as usual on HIV-related deaths, right? So we knew also, working with health economists, that implementing 90 could have a huge impact at all levels on the HIV epidemic. At the same time, we also knew that there were very clear local needs that were identified, and it was not all green pastures under the sky. We knew that there was a need, and there still is a need, to target the right communities with the right programs. The graph on the top shows you the proportion of people from certain communities knowing their HIV status in Asia and the Pacific. That's female sex workers, male sex workers, men who have sex with men, and people who inject drugs. and they're all below 50%, right? So we know that we have work to do there. And we know we need to target the right places. And the map at the bottom shows you KwaZulu-Natal, and the blue spots are the health clinics. And then the different shades of green show you the decline in opportunities to access treatment depending on where you live in the province. Basically what that shows you is the further you live from a health clinic and from a healthcare provider, the least chance you have to access treatment. That sounds totally obvious, but that was a way to show it to people who don't work on HIV. So with that, we chose to develop one initiative that works on implementing 90-90-90, which is the Fast Track Cities initiative. And I will talk to you a bit about the history of the initiative, and I will take a few examples of the way it's being implemented in certain cities and countries. So the Fast Track Cities initiative was actually co-founded by 4 partners, UNAIDS, IAPAC, UN Habitat, and the City of Paris. That was launched on World AIDS Day in 2014, so almost 4 years now. And at the time, 26 cities globally signed on the initiative. They signed on the Paris Declaration, which is the document that we ask mayors to sign and to commit to. It's really centered around 90-90-90, but not only. The main 4 commitments that we ask cities and city stakeholders to make are committing to the free 90s, that's free, and committing to fighting stigma and discrimination, that's the 4th one. And I want to insist on that one because it's very easy to talk about 90-90-90 and the figures and the way to implement the figures only. Fighting stigma and discrimination is more about quality than quantity, but that should not be forgotten as part of this initiative. And it goes far beyond 90-90-90 only. We talk about ending the AIDS epidemic in member cities by 2030. We talk about building, accelerating an appropriate response to local needs, mobilizing resources, which is an issue. And I want to also say here that we don't really believe in doing more with less. I think we've been under a lot of pressure to do more with less. I think it's time to do more with more, maybe. So that's also what the initiative is trying to underline. So why cities? Because there are environments where the risk of transmission is higher, but also where there are accessible resources. There are more infrastructures in cities than in rural environment. Many cities everywhere in the world are centers of innovation on many aspects of implementing new tools and even creating new tools of prevention, information, access to care, access to treatment. And there is a leadership for the HIV response. We found that if you look at political leaders at all levels globally, when we talk about HIV internationally, we always call on ministers of health, governments, international organizations. We very rarely call on local political leaders and mayors. And we also know that many mayors from many cities have been very faithful to the fight against HIV, and it was time to give them a more official and visible role in the fight. That shows you the proportion of people living with HIV in selected cities from the number of people living with HIV in their respective countries, which shows you basically that in many countries, one single city accounts for at least 1/3 of people living with HIV in the country. So targeting cities, of course, doesn't target everyone in the country, but in many countries targets a huge proportion of people affected with HIV and AIDS. There are very few cities from North America or Europe here on that graph, but As you can hear, I'm French. Paris accounts for 60% of people living with HIV in France. You go to the UK, London accounts for, I think, 62% of people living with HIV in the UK. And we have similar situations in many countries. At the same time, the HIV prevalence in cities, on average, is twice as much as it is at the country level. So again, targeting the main cities in countries targets areas where the prevalence is higher and is a way to make awareness campaigns, stigma and discrimination campaigns, new tools, new prevention programs more targeted and maybe more efficient. So the 1990 objectives and targets actually work all along the continuum of HIV prevention and care. What I want to underline here is the red arrow at the bottom on human rights, stigma and discrimination, and access to health services. As an organization of healthcare provider, we really insist on that. We know there is stigma and discrimination in healthcare settings as well. We try to help our members into avoiding being stigmatizing or discriminating, but that is a huge issue that we still have. I will show you what 3 cities and 1 country have done as part of Fast Track since they joined. The first one being Kiev in Ukraine. It was the first city in Eastern Europe to commit to the Fast Track city targets. They do have a city-level strategy that started last year that goes to 2021, aiming at having almost 90% of people on ART. There is a strong political leadership in Kiev. Don't ask me why, but there is. So that's also part of the way that new programs can get implemented locally. And the state budget for ARVs in Ukraine have more than doubled since Kiev and actually Odessa joined the initiative. So it is having a positive impact. And Kiev actually published their data. That's something that we ask cities to do. Kiev agreed to do that. They're far from the 90s, right? But still they're making some kind of progress, and they agree to publish it. And we believe that transparency on the data is very crucial to being honest about what we are doing, what we are not doing, where are the gaps, and sharing best practices with other member cities. This is the data for the Nairobi County, right, which is almost the same as the city. I won't go into the details. And you can see, again, that their big gap is on undetectable viral load, not surprisingly. But again, they agreed to publish the data. They agreed to publish the 2014 data and the 2016 data. And it does show progress. New York is almost at 90. And they also agreed to publish their data for 2015 and 2016. We're waiting for the 2017 one. But New York is also a city that has disaggregated data like some other cities do, but not all of them. And we do need disaggregated data. Working on 90 globally at the city level is not enough. We need to know that what progress we make towards 90 in specific areas of the city, but also in specific populations of the city. If we reach 90 globally at the city level, but the MSM community, the sex workers community, the injecting drug users community lie behind, then we've lacked something and we still have more work to do, and we need to have this data reflected and visible. That's what New York is doing among other cities. They've also implemented a number of new programs as part of their membership of Fast Track cities. Some were initiated before they signed as a Fast Track cities. Some were initiated after. But again, they make these initiatives very, very public. They communicate about it. And they also communicate about their gaps and what doesn't work in the new programs. Portugal. So I wanted to have a very quick focus on Portugal because Portugal was the first country where more than one city signed at the same time in 2017, so last year. 3 Portuguese cities signed, Lisbon, Porto, and Cascais, at the same time. And the next step for these 3 cities was to work together with the Ministry of Health on developing a fast-track cities strategy that would be supported by the Ministry of Health, but would have city-specific components at the same time. It was an iterative process, it was a consultative process. It took about 6 months, which is not so long when you think of it. And they actually started implementing this strategy in the 3 cities in February this year, which actually led to the next step just less than a month ago when 7 additional Portuguese cities signed on the initiative. Again, together with the Ministry of Health, they actually signed at the National Portuguese Parliament. And now the strategy that was developed for the 3 cities last year is being adapted to the 7 new cities. The interesting thing is that about 60% of the Portuguese population now lives in fast-track cities, and 75% of people living with HIV in Portugal live in fast-track cities as well. So having a strategy that is supported by the Ministry of Health and adapted to the environment and the specific epidemic and dynamics at the local level in each of the 10 cities actually addresses most of the HIV needs for the country. Portugal is the first country to do that, and that's a model that we would really like to see applied in other cities. I will take my last 5 minutes to talk to you very briefly about the development of the initiative in Europe. So I don't know if you can see the blue dots, I hope so. You have 4 blue dots here on the map. That's the 4 European cities that signed on the initiative when it was launched 4 years ago. Now this is the current fast-track cities in Europe. And this is the cities in Europe that we are talking to and that want to join the initiative at the moment. So you can see 2 main developments of the initiative in Europe. The first one is that in countries where we had 1 member city, in many of these countries we see more cities who want to join the initiative. That's the case in France, where only Paris was a member. Now Bordeaux is a member, Nice will sign in 2 weeks. We are talking to Marseille, Lyon, and Lille. That's the case in the UK, that's the case in Germany, in many countries. The other trend is that we have more cities from Central and Eastern Europe who want to join the initiative, and for us that's a very important development because the epidemic dynamics are very different in Central and Eastern Europe, as you know. And in some of these Eastern European countries, as you know, we are in cities and countries that are the only ones in the world where the HIV epidemic is still increasing and drastically increasing. So seeing some of these cities wanting to join the initiative for us gives us additional responsibility, but also is a sign that the initiative is seen as attractive by people working on HIV locally. The developments we plan for next year, we will have 1 global European fast-track cities workshop. I don't know when or where, but we will. We've had 2 this year already, and Madrid was included. We will have 1 workshop specifically for Central and Eastern European cities for the reasons I've just explained. We will have 1 Global Fast-Track Cities Summit in London in September next year, where we will invite all the mayors of all the current fast-track cities in the world. That's 250 cities. They haven't gathered together since the first 26 signed 4 years ago, and we think it's time to reconvene the mayors together with all the stakeholders, of course, with clinicians and communities. But we need them to recommit publicly to the objectives of the initiative. And we will have in Europe a series of language-specific workshops, because one of the barriers in the initiative is people like me French coming to Spain and talking to you in English, which means that 90% of what we do in the initiative is all in English, and that is obviously a barrier when we have 5 or 6 cities in one country being member of the initiative. So we want to have language-specific workshops next year, and we plan on having one for all Spanish-speaking European cities. Again, I don't know where or when, but it will happen. So I hope you will all come, and maybe we'll do it in partnership with Resida. I don't know. I mean, just a call. But that's the plans for 2019. We will also need you to come to the summit in London in September 2019. That will be a high-level political summit, but not only. If it's only a high-level political summit, then we'll have missed the target, if I can say so. It needs to include all stakeholders at the city level. Again, one barrier will be language, I guess, but we need people at this workshop. I wanted to acknowledge some of my colleagues and thank you. And you have my email address there if you have any more questions in French or English. Thank you.
I just want you to stand there, Bertrand, so we can thank you for this very inspiring talk. Madrid is a fast-track city together with Barcelona, I believe, and Sevilla. And I think we have to fast-track faster. And it's wonderful to have an ally like you. Thanks for coming to our meeting. And this is our vision for the next few years. So I hope in a not so far meeting, we can share with you progress on how our fast-track cities in Madrid are moving. I'm not sure if as well as Portugal, but we have a lot to learn from our neighbor. Thank you very much.